Good morning, everyone. My name is Yunhe Li. Today I will be present my master project, the automatic segmentation of lymphoma in FDG-PET safety images using convolutional neural networks. I would like to thank my supervisor, Dr. Jake Kendrick, for providing me with this project and for such great support during the past year. I'll begin with a brief introduction of lymphoma. Lymphoma is a type of blood cancer that originates in the human lymphatic system. There are two main types of the lymphoma. The one, Hodgkin lymphoma, which had approximately 82,000 new cases and 22,000 deaths globally in 2022. The another type is the non-Hodgkin lymphoma, which has approximately 500,000 new cases and 250,000 deaths globally in 2022. This represents a significant health burden. Due to the heterogeneity of the non-Hodgkin lymphoma, there are over 60 distinct NHL subtypes, each requiring different personalized treatment. This drives the clinical need for precise diagnostic tools and personalized treatment management. Recent studies have found these powerful prognostic biomarkers, which extract from the PET imaging. The first one is the total metabolic tumor volume, which is the total volume of the metabolically active tumor. And the second one is the TLG, which is the TMTV multiplied by the mean SUV. This incorporates the tumor volume and the metabolic activity intensity. Those PET imaging biomarkers have proven the prognostic values in this meta-analysis of 2,729 patients, which show that the patient has high total metabolic tumor volume, has a threefold higher risk of disease progression or death. But we have the following clinical bottleneck, which is the manual segmentation is very time consuming and it's labor intensive. And they often relate with come with this inter-observer variability. As a result, those powerful imaging biomarkers remain underutilized in the routine practice. In my project, we want to actually improve this workflow efficiency by using the AI model to do this segmentation for us. By running the AI model inference, it actually takes a few minutes to generate a prediction mask. And with the power of segmentation model, it's actually very standardized. It eliminates the inter-observer variability, and which can enable the routine use of those routine usage of those imaging biomarkers, and bring us the personalized treatment with this risk-adapt treatment decisions. How the PET imaging technique works is actually detecting the 511 keV photons from the FDG-Tracer. Actually, this FDG-Tracer release a positron inside your body, and the positron annihilates with the electron in the tissue, and they produce this photon can be detected by the scintillators. The FDG-Tracer is a glucose analog that accumulates in metabolically active cells. The cancer cell is a type of cell that has high metabolic activity, so they show up brightly like this on the PET scan. And after we take the PET scan, we need to do the FDG uptake normalization, which enables the quantitative comparison across different patients. One advantage of the PET scan is actually the whole body coverage and actually capture the complete disease burden in one single scan. By combining the PET imaging with the CT, we actually has this both anatomical and functional information, which is really useful to train segmentation models. The traditional machine learning approach is actually using those handcraft radiomic features fit into the shallow classifier, but nowadays a deep learning technique actually uses automatic feature discovery through this hierarchical learning architecture. One of the really state-of-the-art architecture is this Yunhe architecture, has this encoder-decoder structure, or encoder-decoder structure with the gate connections. This structure is ideal for the medical imaging segmentation. And the 3D extension of the Yunhe actually can handle the volumetric PET-CT data natively. This slide presents the literature review. As you can see from the first one, there are impressive progress in the recent year studies. You can see the size from the recent year studies is quite high compared to the first one from AutoPET 2. Maybe they only have 0.4, something like that. JMAS team achieved a dice of 0.98 with this cascade 2D plus the 3D units, and this really huge number of patients, almost 3,600. And John's team achieved a dice of 0.78 with this diffuse large B-type lymphoma cohort as an external validation. The Rucos team is actually the winner of the AutoPET 3. They achieved a dice of 0.68 with this really challenging multi-institutional dataset. The rest of the teams actually have the dice range from 0.64 to 0.98 across different datasets. And these are the identified gaps from the current literature review and studies. The current studies is actually limited by the model's direct comparison under the identical conditions. For example, the pre-processing of the data, the training, evaluation, post-processing. And some model is actually has this domain shift challenges when moving between different institutes. They have different scanners, they have different protocols. And we don't have this subtype-specific performance where showed with this subtype-specific variation is poorly understood. In this project, my aim is to address those gaps through this rigorous comparative study. Research objects. In my project, I have 4 primary research objects. The first one is develop this standardized pipeline, implement the nnU-Net model with large residue encoder preset as a baseline model, and this same model with extra large residue encoder as the scaled version of the model. And the final one is the LesionTracer team implementation. It actually is our advanced model. And all model is trained with identical pre-processing data and everything, hardware. The second objective is the internal benchmarking using bifocal validation on this 1014 case dataset from the cancer imaging archive. After that, the third objection is to do this external testing. I will I tested the best model from decided from the internal benchmarking on this 60 case international TMTV benchmark dataset. And the following clinical, the best model was used to extract these clinical biomarkers, and I developed code to automatically compute those biomarkers and with the accuracy assessment. This project comes with this rigorous methodology. We use comprehensive matrix, the voxel-level overlap, the lesion level detection, and the biomarker correlation. And in this project, I also analysis this lymphoma subtype-specific dataset which have the diffuse large B-cell lymphoma, Hodgkin follicular lymphoma from the testing dataset to understand the performance variations. A little bit more detail about the training dataset. We have 1,014 whole body scans from the University Hospital Tübingen, and this actually compares of 501 positive case and 530 negative control cases. In that positive case, we have only 145 lymphoma, 188 melanoma, and 168 lung cancer. And they use this Siemens CT scanner with this standardized protocols. The annotation from this training dataset is by expert implementations of all FDG evaluations. The external testing set is from another paper called International TMTV Benchmark. It has 60 scans, 60 lymphoma scans from 5 different trials. And they have this 3 different subtype of lymphoma. And the annotation is created by 5 expert readers by this 4-step TMTV workflow. After that is the pre-processing of all the data. First, all the data from the TTA website is in the DICOM format. You have to convert everything to PPT format, and all the PET scan is normalized to body weight SUV for further model training. Every CT scan is resampled to PET grid, serving the hospital units. And the mask is using this nearest neighbor interpretation to ensure also perfect alignment between all modalities. These 3 segmentation models investigated in this project. You can see from this table the model architecture. Comparison shows the difference in the backbone, the design, the encoder weights, and training characteristics across 3 different models. Our baseline model, the nnU-Net model with large residue recorder preset, has this 3D residue net backbone with self-configuration capability. It actually can configure itself based on your data set. It extracts the fingerprint from the data set. And this model provides a robust out-of-the-box performance, and it's widely validated across different types of data sets. The second model is the nnU-Net model with extra large residue encoder preset. This one, the only difference is actually here. You see the patch size compared to the large one is larger, and from that we have larger receptive field through the bigger patches, and we have more content which can improve the lesion detection. Our final model is the LesionTracer model. This model uses the multimodal pre-training using 4,000 CT, MR, and PET scan, PET images. And this model has this dual head architecture, one with lesions and one with 10 organs. This model utilized the misalignment argumentation to simulate the real-world PET CT registration errors. And from this organ mask, the anatomical priors from this organ segmentation actually reduce the false positives in the physiological optic region. This is a example of the perfect and ground truth mask for a diffuse large B-type lymphoma case. Now the results. From the internal validation, the voxel-level first. From all those plots, you can see the LesionTracer model actually achieved the highest mean bias at approximately 91.2 compared to this 87.6 for the extra large encoder and 77.2 for the large encoder. Also, the LesionTracer has the smallest. Okay, sorry. The LesionTracer has the smallest accuracy from the plot, which indicating the most consistent performance. And from the false positive and false positive volume, false negative volume plot, you can see for all models achieve median FPV at NV near 0. Should have a line here, but it's really hard to see. Sorry, I need to plot some. Yeah. I will improve the plot in the future. And the LesionTracer model maintained the tightest IQR range for both of them. Next one is the lesion level matrix. And for the lesion level matrix, I use this connected component analysis to identify the individual lesions in both prediction and ground truth masks. And a lesion only counts as a correct detection only if two masks, two lesions have any overlap, at least one voxel. And from those plots, you can see the large resident the model has really good sensitivity, but really poor prediction. Yeah, indicating there's many false positive detections for this model. And for the actual large resident encoder model, actually shows the opposite pattern with high prediction but low sensitivity, meaning it's missed small lesions. The LesionTracer model achieved the best balance with the 84.2 per lesion and 76.1 sensitivity, resulting in the highest F1 score at 77.8. This slide shows the scatter plot of TLG, lesion count, SUV max, SUV mean. I know this is very small, but all the value I actually present in the next slide. Okay. Actually, from this table, you can see the LesionTracer model shows the strongest correlations with ground truth across all biomarkers, all above 0.9 except for SUV mean and 0.847. And the statistical testing confirmed that the LesionTracer model significantly outperformed both nnU-Net variants across all biomarkers with p value less than 0.005. Now, based on previous internal testing validation results, we have selected the best model, the LesionTracer, and it was select and further test on this TMTV testing set, and you can see the external validation is actually highlighting the challenging reality of the domain shift. The performance on the TMTV benchmark dataset, you can see the dice decreased to 0.66%. It's a substantial performance drop, almost 31.2%. The original model by Ruku's team, trained on both FDG and PSMA capacity data from the output 3, they actually achieve a dice of 0.66 on the external FDG only testing set. And given the difference between their testing set and our testing set, I think the 10% performance drop is considered maybe reasonable. This plot shows the lymphoma subtype specific performance on the lesion level matrix. And you can see that for different color, it's actually different type of lymphoma. And you can see the variations across lymphoma subtypes. The LesionTracer still achieved the highest lesion level position. Highest lesion level position and sensitivity on the Hodgkin lymphoma, the green one. And it's achieved similar results on the diffuse large B-cell lymphoma and follicular lymphoma. But the DLBCL lymphoma, they actually have a slightly bigger spread. Okay, this slide shows the scatter plot of those biomarkers, plot with 3 lymphoma subtypes. And from this plot, compared to the internal one, you can see the correlation actually become more weaker here. For the biomarker correlations, the TLG shows the highest. This one, the TLG shows the highest correlation at 0.7, followed by the TMTV lesion count, as you mean, which are all above 0.64. However, the SUV max shows the lowest correlation at only 0.1218. The variations of those biomarker correlation across different lymphoma subtype are very notable on this table, and it's indicating the model performance varies by different subtypes and may require the subtype-specific adjustment for optimal accuracy. Yeah, this slide shows the blend ultimate analysis of the total mathematical voltage. You can see the overall bias here is that below 0 is actually minus 107 cubic centimeter, show a general underestimating of the TMTV. And the limited agreement from minus 800 to almost 700 cubic centimeter show substantial variabilities here. And from this residue plot, you can see there are this subtype specific arrow patterns for diffuse large B-cell lymphoma. You see this underestimation and really large spread. For follicular and Hodgkin lymphoma, you see slightly overestimation here. And also it's the mean value here. Yeah, this slide shows the blend optimal analysis for all 2 SUV matrix. The SUV mean actually has the biased coordinates with the smallest bias, only 1.8, and the tightest LOA limit of agreement. And the SUV max actually show a systematic overestimation and is problematic, even higher overestimation and larger spread for high uptake lesions as the value goes up, we see more overestimation, larger spread. This slide show the lesion count residue plot, prediction minus ground truth. From those plots, you can see for all subtypes, it's actually overestimating the lesion count. The median error is about 10. And from this, we can see the false positive detections actually inflate the counts. And the model, we can conclude that the model is too sensitive, maybe to the low uptake regions, mistaking some normal tissue, classified as lesions. This is the post-processing strategy we used in this project. The first one is just the raw model output. Second one is remove the voxel below SUV4. And the third one is actually adding the additional volume threshold, removing any lesions smaller than 3 cubic centimeter. You can see this statistic here. The raw model output, and actually only have 43% median bias, really low, and highlighting that the model alone doesn't learn the lesion boundaries very well. And after we apply the SUV4 thresholding, it actually improved the bias to 60%. It's a 70% depth improvement, and it gave us the optimal balance. And after we apply the additional volume filtering, it's improved the visions here. Yeah, actually, yeah, improved the vision by half the sensitivity. All results presented before, they're actually using the SUV4 threshold, the second corresponding technique, because the dataset from the TMTV international TMTV dataset, their ground truth is actually using this SUV4 threshold. That's why we use the same one. And from this, we can see the subtype dependency. The Hodgkin lymphoma is most affected. 40% of voxel is removed by this SUV4 threshold. And for the lymphoma, it's only 28%. And for the DLBCL, it's 14%. This is the strength of study. This project presents a direct architecture comparison of 3 nnU-Net variants with identical pre-processing, training, and evaluation. And we evaluate all the model performance based on the voxel-level overlap, lesion-level detection, and biomarker correlation. And we have this clinical focus on the. But why we have a clinical focus on the biomarker? Because they actually show really good prognostic values. And the technical contribution of this project, actually we deliver subtype-specific analysis across 3 lymphoma subtypes, and we have this post-processing optimization with the clinical rationale, which is reducing the false positives. And the clinical relevance of this project, actually we kind of address the real bottleneck of the manual segmentation, because our model only need a few minutes to generate a segmentation map. It saves a lot of time, and we don't have the inter-observer availability. And this project also quantify the automation readiness. We identify the performance gaps and the systematic bias of all imaging biomarkers, and we provide this implementation guidance. We have this testing recommendation. We have the model deployation and biomarker extraction code ready for anyone who want to use. Here's the limitation of the current study. For this project, we actually have 3 performance challenges. The first one is the domain shift impact. When we shift from the internal validation to the external testing, we have a 31.2 drop. And this may be due to the limited lymphoma representation in our training set. We only have 125. And the internal validation and the external testing, they actually have different scanner and protocols because they come from different cities, even different countries, I think. The biomarker estimation error for the TMTV actually show the subtype dependent bias patterns. For DL, BCL is actually underestimating, for other 2 overestimating. The lesion count overestimation across all subtypes. The actually max 6 overestimation for all subtypes. And we have this subtype specific variability. The performance for different lymphoma subtypes is different, ranging from 55% for Hodgkin, 72% for follicular. And these different error patterns require subtype aware calibration. And we have some data limitation comes from the testing, right? The first one is it only has 60 cases, 20 cases per subtype is quite small. And the ground truth variability for 8.3% of the cases have more than 25% reader disagreement. And for this testing set, we are liking the inter-observer variability only contain one segmentation, one ground truth mask for each case. If I have 2 or even more, we can calculate the inter-observer variability for this testing set. And the protocol standardization. This trial data may not reflect the routine practice. Another huge limitation of this project, actually, we only explore 3 nnU-Net variants. So maybe future work can, we only explore the nnU-Net variants here. Future work, the first one is actually develop this unsupervised domain alignment methods, such as the universal feature matching to improve the model generalization across different institute, different data sets. And we want to, the second one is we want to integrate this advanced loss function, focal boundary aware loss, and maybe this 2-stage detection segmentation pipeline to optimize the balance between precision and sensitivity. And we want to maybe design this lymphoma subtype aware architecture, which incorporate the histology informed input and can apply the fine-tuning strategies specific to the lymphoma subtype. The fourth one, we want to investigate more different models, such as transformer-based or hybrid CNN transformer model to capture both local global contextual information in the PET segmentation. This is one advanced application of this project. We can apply our AI model in the CAR T therapy to predict the treatment response. Why we need to do that? Because for the relapsed and refractory diffuse large B-cell lymphoma patients, their 1-year progression-free survival rate is only 68.4, and this cytokine release syndrome occurs in up to 93 of the cases. And the toxicity, neurotoxicity, actually occurred up to 70% of the cases. It's a huge opportunity for AI to integrate our segmentation model and automatically calculate the biomarker and combine our PET imaging biomarker with the clinical parameter to predict both treatment response, toxicity risk, and survival rate. The current AI model is actually progressed from the proof of concept to clinical calibration stage. Even though the current segmentation model is far from perfect, but it is demonstrate this capability represent a significant step towards the integration quantitative imaging biomarker into the routine lymphoma treatment management. Okay, so huge thank to my supervisor Jake, huge thank to Benjamin for all the support for everything. And I want to thank Nathaniel, Jake, Kaylee, Joe for running the machine learning cluster. Thanks to all my peers for the wonderful journey studying medical physics together. Reference. Any questions?
Might be muted, Martin.
Oh, sorry, I didn't realize I was up. Thanks, Yunhe. That was a really terrific presentation. It was great to see your project evolve over the last year or so, and what you've produced is fantastic. Couple of questions. So the first one is the performance drop on the external validation set. So the 0.6 DC is not a great outcome, but then it didn't seem to be great for anyone else either. I sort of wonder how much do you know about that external data set and how robust it is, and if there's been any sort of independent evaluation of it. Maybe it's not a very good external validation set.
Actually, for the external testing set, it is a relatively new testing set. I actually didn't find any team actually train their model testing on this set. I think we are the first team to actually do this. Maybe I will go back to look other team. Maybe they have different results. But the current result from the AutoPath 3, they train their model. They evaluate on another data set from different institution. They suffer the same performance drop, I think. They have the DAS from 0.77 for the same center and drop to 0.66 for the different center. Did that answer your question?
Yeah, I think so. I just sometimes people put a lot of trust in these external validation sets, like there's some sort of gold standard, but yeah.
We choose this specific external testing set because it's comprised of 60 lymphoma cases, which is very important for us to evaluate our model, the readiness for the lymphoma treatment prediction thing, because the data set from the TCIA, they only have 145 lymphoma, is only maybe 20%, 10-20% of the total data, but our testing case is all lymphoma and has 3 different subtypes. That's why we're picking this data set, and we want to validate our model on these lymphoma cases. Yeah.
Sure. Okay, the other question is, so there was a fair bit of uncertainty in the biomarkers that you extracted, but do you know how accurately they need to be predicted? So if you can, if you're looking at the change in those biomarkers for an individual patient before and after treatment, for example, how accurately do you really need to know that total volume, for example?
I think this part will be a future work for the project. They need to actually investigate how much the biomarker, the statistics they need for the deployment for the future. Thank you.
Sure.
Thanks, Martin. Mubasher?
Okay, hi. That's good work, to be honest. I like, I'm not surprised to see the result that actually testing an excellent external validation or a testing set, like one of this trend is not performing well there. I was not expecting 30% drop, but actually, to be honest, I am expecting 20% at least in biomedical imaging. Yes, unfortunately, many people are happy with the validation test rather than independent testing sets. Now, my question is that, first of all, with this like 0.6 performance, which is pretty much slightly better than a flip of a coin, it looks to me that it is not actually good enough to be embedded into the existing system or assisting, to be honest, experts for segmentation. The point is that do you think like it is basically the limitation of the model, or is it the limitation of the data set that we do not have such a good result?
Yeah, I think it's a limitation from the data set actually. Our training data set only have less than 20% lymphoma cohort, but we're testing on 100% lymphoma cohort. I think that's why we have the huge performance drop. If we can train this model on a huge data set with different type of lymphomas, I think it can boost the performance, the model performance a lot.
And other question is that, do you think that it will be feasible or it will be more beneficial if we have different models if we have enough data, different models for each type of lymph node rather than actually having the same model trying to detect all four or three of them?
I think the same model will work because the LesionTracer model we use, they have this organ mask. If we want to deal with different type of lymphoma, we can fine-tune the model mask specifically to those lymphoma subtypes. For example, you have this set of organ segmentation for diffuse large B-cell lymphoma, different segmentation for the follicular and Hodgkin. Actually, you can do a lot of fine-tuning on the current LesionTracer model. You don't need an entire different architecture, just fine-tune the organ mask thing. Yeah.
Okay. Yep, that's good one. And just for those who are taking this, maybe for you or someone else who is taking it actually in future, I will be saying rather than transformer models, it will be good if you can actually go ahead with the Mamba architecture because it is faster and it has been proven to work better on very small segmentations. So just giving an idea for everyone.
Okay. Thank you.
Thanks. Well done.
Thanks, Michael. Anyone from the room have a question? Yeah, one of you guys.
Okay. Sort of semi-related. I mean, beyond the fact that there was a limited number of lymphoma cases in the training set, you think the fact that just over half the training set was negative cases, while the testing set was all positive cases, do you think that's significant? And do you think the actual clinical use case of the model, would you always be expecting positive cases for your patient? Or is it important?
Yeah, we're expecting both positive and negative cases because for some maybe they mistake the physiological uptake as a cancer, but our model can actually verify it's not a cancer, but it's actually a negative case, but the doctor maybe mistreat as a positive case. Sometimes it maybe happen, I think, for really faint lesions, for really small lesions. And for our testing set, we have all positive. But for the LesionTracer team, their external validation set, they include negative cases, I think. But it's not 50%. I think it will be 20s, 30%.
Just wanted to ask, well, how do you think you could expand on the LesionTracer team's methodology to improve the performance? Like you mentioned, more sort of dramatic changes in model architecture, but just taking their methodology as is, what do you think you could do with that?
To improve the LesionTracer model?
Yeah.
As I said before, I think we can develop the specific organ mask using the total segmentator for different types of lymphomas. Because we have this huge heterogeneity for lymphoma, non-Hodgkin lymphoma, we can develop different organ segmentation structure for different types. And you can train them separately on just this lymphoma subtype data. It will maybe improve your performance. Yeah.
Right. So, quick question.
Yeah, sure.
Great talk. You had a lot of hard work put into this project. I just wanted to ask, do you have any idea, like in the literature, with respect to inter-observer variability for segmenting these kind of lymphoma lesions? Because I know in standard organ segmentations, you may get like 7.8 between two clinicians. That's typically a decent threshold.
In my thesis, I briefly mentioned about the interoperability for those literatures. They actually have for their minute segmentation, they actually have a really high agreement. I think it's about 0.9 for most of the segmentation methods they use. Yeah, it should be in the thesis.
Sorry if I missed that, but that usually puts the model into context.
For example, for our particular testing set, the ICC, the interoperability, is quite high for 87% of the case. Only 13% of the case they have a disagreement about 25%. So the interoperability for most of the segmentation, human segmentation, is low. They have a really high agreement. Yeah.
Thanks.
Sorry.